I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to Women's Health Unplugged. Today is going to be a really informative episode. We're kind of talking through, the problems and the promises of 3 different kinds of medication options for hormones in your 40s. It's really common when I'm working with women that have either already been offered treatment from another practitioner or when they land in my office, that they feel like they're getting, I'm going to say in air quotes, the wrong prescription. So they've talked to their doctor about something and they've left with the suggestion of an IUD, or they've talked to their gynecologist about something and they've left with a prescription for an oral contraception, or they've read online that the right thing to do is to be on HRT. And it's left a lot of confusion about these 3 drug classes. I always tell patients that when you Google something, you have to remember that you're getting sort of that TripAdvisor kind of feedback about any medical, recommendation. I'm saying nobody gets on TripAdvisor to talk about the mediocre chicken. They all get on there and talk about their food poisoning. And that makes it difficult to make good decisions for yourself if you're hopping on a message board and everybody who's ever had an IUD had it fall out or get displaced or what have you. So there's no better person for us to have this conversation with than one of my friends and colleagues, Miranda Tawfik, who is a pharmacist that owns Origins Pharmacy in Oakville and is a part of the Oakville Trafalgar Hospital pharmacy network. Thank you for coming on, first of all, Miranda. And we were just saying as we hit record, it's been so long since we've actually seen each other in person that I feel like we should be doing a better job of that.
I know. I think it's about 2020, but it's always
I
good
think
to
so
see
too.
you. Yeah, and talk to you. So we're in touch every once in a while, right? On email and text. Life is crazy right now. So
It is. And given that our offices are, I don't even want to do the Google Maps, but I think we're probably less than 10 kilometers apart at this point. And yet here we are on the Zoom. But Miranda, I've always appreciated, so first of all, you have like a big women's health focus in your pharmacy, lots of hormone prescriptions, lots of conversations with women, with pharmacists, with physicians about the appropriate care for people from a hormone perspective. I would love for us to, kind of like right some wrongs about the way that people feel about these particular medication options, because what I would like listeners to leave today feeling like there's no like obvious wrong choice when it comes to supporting hormonal symptoms in your 40s. It really kind of comes down to, what's best for that individual woman. But can you just give us a little bit of insight about your experience in working with this age group and why you're so interested in supporting people in their 40s with hormones?
It's so funny. I was just thinking it's been almost 20 years since I've been, a pharmacist. Probably, 20 years now. And my first patient was actually my mom. And when you come out of pharmacy school, everything seems black and white. Here's the treatment regimen. You have high blood pressure, you go through A, B, C, and D. And then I remember seeing my mom, and I was in my 20s. So I didn't know, you're still a little self-centered. And, my mom was like a superwoman. So she was always active, busy, working, this, that, helping, anybody and everybody. And then I remember when I started working, she couldn't leave her house. She went from unable to sleep. And I was like, what is wrong with you? And I wasn't thinking hormones at the time. I'm just like, what is wrong with you? She's like, I don't know. I just feel like I can't get out of bed. I'm not sleeping. I don't feel myself. Her mood changed significantly. So I said, you go see your doctor. She went to her doctor. And of course, she got an antidepressant. And I remember thinking at the time, I had no qualms if, take it if you need it. She had never been depressed in her life. That was not, her situation. And I said, this can't be right. This can't be right. And I had just started, compounding, and I love always finding solutions and so on. And by chance, I had met with a physician who was doing hormone replacement. So I said, you have to go see him. And sure enough, her hormones were out of whack. She was totally devoid of anything, because right before that, we had taken her off also the synthetics, the oral estrogen and the Provera, right? Because at that time, studies were coming out and so on. So she was just a disaster. And she ended up taking bioidentical hormone replacement. And I kid you not, within a week, she was back to herself. And all she turned to me and said, why didn't anybody tell me this? I've been suffering for a year. Her work performance declined, and she was an engineer, so very male centric environment. So you can imagine there was already that kind of pressure on her. And she was worried about losing her job. She could not physiologically perform. And that's where, when that happens, and then you start talking to women, it's like when you're driving, you see, you point out a red car, all you see is red cars. And then, so that's what happened. And I just thought to myself, like, this cannot be. So I got very, very focused and did, extra training in women's health. When I see a woman who's like the foundation of her home, right? And her community, and she wanted to do so much and she couldn't for no good reason, and it was preventable. That's why I really, really, took a focus on women's health. And 20 years later, it's the best thing that, I've ever done, most fulfilling and the most rewarding, because you see that impact.
That's such a great story. And your mom, she did some cool, brave things in there, actually, right? That post Women's Health Initiative, which was the big trial that made everybody nervous about hormone replacement therapy, which has now mostly been retracted in various parts of that. For her to go back on hormone therapy would have been brave, because there were some concerns at that time, right? About just not us maybe even understanding about what all the benefits and risks were, but also she was brave for being an engineer back then as a woman. So
I know, isn't that
quite the role model there?
Yeah. It was, it was tough to see this, this superwoman just decline in that manner right in front of our eyes, right? So she's just one of millions, really, at the end of the day. And so when you think about, a woman in her 40s, she's either caring for her parents or caring for children, right, who are a little bit older and likely give them a hard time. You have to be in tip-top shape. You have to, whether you work at home, whether you work outside of the home. I just find that we are really, I know this sounds a little much, but we're the cornerstone of society, and no matter what, we do so much and we take care of everybody. So if we're not okay, it's detrimental, just not to individual households, but to society.
Yeah, 100%. And it's interesting when women like that I work with say, well, I don't remember this with my mom. I don't remember this with my grandma. And I'm like, yeah, but their lives were so different than yours, right?
You may not have spoken about it, right?
That's right. I'm saying my Nana wasn't allowed to have menopause, right? That's why we don't know anything about it, is because that wasn't even okay for her to complain about it. So so I want to talk through these options, right? Because like I said, I think with the three, there's certainly lots of medications that can support people during this phase of life. But the three that I always end up having to do that differentiator for women is the pill, the IUD, and then hormone replacement therapy. There's pros and cons to kind of each of those drug classes, or there's groups of people that are going to respond really well to one, or it's going to cover more of their symptoms than the other. So I would love if we could kind of talk through that. Maybe starting with the pill. I mean, my experience of doing research on the pill is Canada has maybe some of the the smallest variety out there as far as oral contraceptives. There are other countries that have much more innovative solutions for oral contraceptives versus what we have. But what's your experience with like the current oral contraceptives on the market? What are people looking for in an oral contraceptive? Like, why would that maybe be a consideration for someone over 40?
Well, I mean, birth control, right? And if they have any other factors that they want to take care of at the same time, like acne. I don't see in my personal practice, I've seen quite a decline in birth control in this age group. I'm seeing more of a trend like for birth control, IUDs, right? It's more localized, less risk, more of the progestin, instead of the estrogen. But that's also good for somebody who's bleeding excessively and who wants, birth control. I don't know about you. Are you seeing a lot of birth control pills prescribed?
I still do see it. Yeah, I still see it. Or that people have been, maybe in air quotes, left on their birth control into their 40s, and that their doctors aren't in a rush to change their solution because it may be covering aspects of their perimenopausal experience. And so rather than taking them off of their oral contraceptive, they kind of get well, you can just stay on this right up until menopause. I think that's something that I'm experiencing. But you called out some important points there. Like, I think sometimes even when cycles are irregular and women are aging, they forget that they can still have an unplanned pregnancy in their 40s. Which carries lots of risks, right? I always say an unplanned pregnancy is one of women's greatest health risks. And so for women that are in new relationships or their lives are changing and they're, maybe having unprotected intercourse with a new partner or what have you, you can definitely have an unplanned pregnancy in your 40s. And as far as, sometimes women are like, well, I want HRT, right? But when we go through their history, I'm like, you are not out of the woods as far as pregnancy goes. Like, let's start there. Like, this is something that we need to take care of. Yeah. But I definitely will see women get kind of left on their pill, and that always raises lots of questions for them about the safety of that or whether or not the benefits outweigh the risks. How do you counsel patients about that, or what are some of the questions that we should be kind of thinking about?
One, are they tolerating it, right? So there's different types of birth control. So just like anything, if they've been on it and they have to use it for birth control and they don't want to use an IUD, or they don't want to get their tubes tied, or, there's still other options. And I do remind them that, like, also their partner can get a, vasectomy if that's, it doesn't always just have to be our bodies, being destroyed. I think not destroyed by the pill, but you know what I mean? Like, there are other options. And so that's how I usually counsel. I let them know all the options, not just for their bodies, but also, so if we're discussing unplanned, or concern with pregnancy. But I do find that, and again, it's tapered down quite a bit in what I've been seeing over the last few years. If they're managing, if their symptoms are okay on the pill and it's doing what it needs to, and that's what they're comfortable with, we know that they won't be on it indefinitely, right? There will be a time where, probably within a year or two, I do remind them of certain risks, right? We do know, I do like to understand their lifestyle. Like, are you a smoker? What are your other, are there any other health risks that we should be aware of, right? Because that can change from year to year. And that's why I always like to update my knowledge with everybody at least annually. Did they take on smoking? Did they stop smoking? What's, drinking like? Did they have a clot that, we don't know. I mean, there are risks to it. In so many cases, you can go without, if people are okay on it, we know it's temporary too. But I think it's important to provide them options that may not have been disclosed to them by their, whoever. Yeah.
I find that too, if people have been on that same medication since they were maybe in their early 30s and
Yeah.
they just kind of get left on it, their prescription gets renewed all the time, and there isn't that discussion about, well, what else is there? And it's important for people to know that, like, women will often ask me, like, well, how do I know if I'm in menopause when they're on the pill? And I'm like, well, we won't know, right? The pill, if you're on a combined oral contraceptive, it's delivering more estrogen. We call it a super physiological dose of estrogen, meaning that it's more than your body would have made anyways, which is why when you're on it, you won't have hot flashes. You probably won't have vaginal dryness. Usually if women have symptoms, it's more vaginitis than vaginal dryness.
Yeah.
You probably won't have some of the like sleep disturbances, and your mood may just be meh, right? Like it may
Yeah.
not be one way or
Status
another.
quo. Yeah.
And so it masks it. Well, it's not masking the symptoms of perimenopause, it's treating them, right? I
Right.
guess is the right way to say that. But it doesn't give us a lot of insight to where you are in your hormone journey. If you've taken the pill right up to 49, like I have no idea where you are. And there's no blood test we can do either at that time to find out.
I don't have a strong opinion, but I think it's important to educate them, because when you do follow up, even when you are refilling a prescription, like in my world, I think it's so important to not just dispense a medication. We need to follow up. We need to make sure that, 3 months ago or 6 months ago, they're at the same place as they are now, or are there new symptoms coming up that need to be addressed? Or did you have a change of heart that, you want to consider another alternative? Or maybe you
Mhm.
are experiencing other symptoms that are not affiliated, and we need to address that.
Yeah, like if I was going to summarize how I feel about the pill, like certainly there's the contraception part that's like
Yeah,
way up there. I liked
right.
that you mentioned acne, and sometimes there are sometimes ovulation is part of the problem for people, and people could ovulate right up until they're 51, 52. And if ovulation is part of the challenge, because when we get to the IUD in a second, you're going to ovulate while you're on your IUD. So if ovulating is the issue, whether you have PMS, PMDD, whether you have an autoimmune disease that flares when you ovulate, like I could maybe think of a bunch of reasons why ovulation for one particular patient would be a negative.
Yeah,
And using the pill, although maybe the doses of hormones are a little higher than we'd love,
yeah,
it obliterates ovulation, which for some women that is net positive, right?
right.
But
Absolutely.
for the well-intentioned woman who maybe is going to want to be on HRT at some point in her life, who maybe wants to understand her hormones and what natural cycling actually even looks like, who's
Right.
just been on the pill and now her life has changed, she no longer needs it from a contraception perspective, then I agree with you. I think us revisiting that and saying, well, what are the other options are important, but nobody needs to be ripped off the pill. It's more
No.
like, which sometimes when people come and see me as an ND, they're like, either they're nervous to tell me they're on the pill
Yeah.
because they don't want me to take it away, right?
Right.
Like never would. Or they feel like they're like, well, I'm on the pill and I need to get off it. And then when we investigate, I'm like, might be the best thing actually. And so I think that's important to kind of remember that there's going to be some people that this is a great choice. And then there's going to be some people where you've matured beyond this option and we should look at something else.
Absolutely. Absolutely. Isn't that true for so many things in healthcare? You've got to reevaluate. Like your body is ever evolving, right? And so it's important to know to give that patient like the autonomy, right? And that's why that good communication and really sitting down with them and understanding where they are at their life. It's important to have those conversations and see what's really medically necessary and then tweak as necessary, right?
And I alluded to that just Canada's choices for birth control are just like terrible. And maybe that will change over time because there are some neat options that are in other countries that are using different forms of estrogen and then different progestins, that, maybe one day we will feel slightly differently about it and say, that maybe the birth control pill will sit on a more equal playing field into the 40s. But right now, Canada has the lowest selection of options in the developed nations globally.
Yeah, and you know what? That's a political and a financial decision usually, right? And that's true for so many different medications, and especially women's health medications, which are not very, numerous to
Prioritize.
begin with or prioritized. Absolutely.
Mhm.
So I will wait and see.
Mhm.
I wouldn't hold
I
my
know it
breath.
always makes
It
it tough
is
when I
great.
find something in the literature and I'm like, oh my God, this is amazing. I'm like, what's the trade
So
name for this drug in Canada? And it's like, oh, this is not available in Canada. I'm
I know.
like, oh, that doesn't make any sense, but that's fine.
I
Um,
know.
let's talk about the IUD. So I'm a
Yeah.
big fan. I'm a big fan of the IUD, and I think I have a gynecologist friend who jokes. She's like, it's the birth control most used by gynecologists, which I don't know if that's true or not, but
It
um,
is. We see it a lot. Yes. That's what I'm
yeah,
seeing more and more and more of.
so let's talk through that a little bit, and what like the pros and cons are there, how it works. Like, can you tell us what your thoughts are about the IUD?
Well, the IUD is great. So, there's one that comes to mind. The more common one is called Mirena. Can I use yeah. And,
Totally. Yeah.
and so that lasts for 5 years. So it's fantastic. So you make an appointment with the OB-GYN, they'd insert it. You might get a little bit of cramping and so on, but risks it stays in for 5 years. It stays in and you don't have to worry. And I believe local is always, is usually better. So if you can, if you're looking for a form of birth control, I think it's an excellent option. And people are a little bit, access is very important. So it is a higher, let's say, upfront cost, but over time, it ends up being cheaper, than keep on refilling your birth control. So I think it's a great avenue to women don't feel it. You don't have to remember. It's one less thing to worry about. It's local. I just feel like there's so many more advantages
Mhm.
to that when it's, properly indicated.
Yeah, I agree. I would say if a patient comes to me and they're having hot flashes and they have an IUD, I'm like, this is like money. This is like the perfect scenario. And it's so, the indications there, right? Like, so it does give us that birth control component, right? Which we were happy about the pill because of that, but the IUD also provides contraception, whereas HRT does not. So we're going to get there and talk about the cons maybe of HRT, but we get the contraception, but also sometimes women don't realize that they still ovulate while they have the IUD. It's,
Right.
often in that first 6 months, you may not ovulate, and that's probably why we get so much spotting in the first six
Yeah.
months after insertion. But it's very unlikely that you won't ovulate after that first 6 months, which means women get to enjoy and experience their own hormone production. They also can stay a bit more connected to their hormone production. That said, you have to track it because I mean, I don't know the statistics. I don't know if you do, Miranda, like how many people continue to menstruate while they're on the IUD versus have zero bleeding.
I don't know the statistics. No, I don't remember that at all. I'm
Yeah.
sorry.
So some
Yeah.
women, and I don't, and maybe we like, I'm sure we know, but I don't know them offhand, but some people don't have bleeding episodes while they have the IUD. And so they can be a little disconnected from their period
That is,
because, right, they lose
that
that
is
feedback.
but a lot of, that's also a benefit for so many women, right? They don't want to be, bleeding as well. So yeah, but there is a con because then you can't, track later on. But again,
Yeah.
it's extremely convenient for women. It's a great option. And then I also think, in terms of the pill, even dealing with acne, even though the pill is helpful for acne, there are other modes of treatment to do that might be less risky. So everything's a risk benefit analysis, right? It's never just 100% okay. You just want to evaluate, right? So
Yeah, absolutely. Yeah, you're totally right about like the lack of period as being a pro. I think my recommendation, especially for women in their 40s, is to just try and stay connected to their PMS experience or that ebb and flow of their cycle, so they can start to see, because that diagnostic criteria for perimenopause is that your menstrual cycles need to be varying by more than 7 days. So if you have always had a 24-day cycle and now you have a 40-day cycle occasionally, you're meeting that diagnostic criteria. But if you never bleed, we never know. And so that, tracking, whether it's mood or breast tenderness or cervical mucus, just something to stay a bit connected with your ovulation, I think can be quite helpful. But tell us about the heavy bleeding, because this is where I think it can be such a valuable tool for people in their 40s.
Right. Well, there's so many options, right? I remember when I was going through something and I went to see my, an OB-GYN. She was new to me. The first thing she offered was a hysterectomy. The second thing was a pill for heavy bleeding. And then the third thing was the IUD, and I had already had an IUD. And then the last thing, I think she didn't even recommend progesterone. So again, there are so many different options. Of course, it will help with, right? It's a progestin, so it will help with the heavy bleeding. But there are other options depending on, instead of committing, for 5 years for something like this, or if somebody doesn't want to pay, again, access is so important. Like, you see so many people, of course, everything's offered to them, but if they can't afford it or they don't want to pay for it, we have to have alternatives. So
Absolutely.
it does help significantly with that bleeding. It's, again, local, but there are other alternatives for that if that's just the indication.
Yeah, I like that you brought up sort of that access piece, because it's so easy to forget that, right? And if people don't have insurance or don't have a drug plan, then that may be helping us make that decision with them, right? Rather than just,
And
looking
sometimes the drug plan won't cover that, but will cover, other
else.
things that could help. Yeah. In my world, access is everything, right? You see the strangest things with the insurance companies, and I'm noticing now even insurance companies are tightening up. So it's more important for us as frontliners to, work with the patient to get not just what we think is best, but what they can afford and continue, their therapy on. So.
Yeah, I like the IUD for that heavy bleeding. I find, especially when patients have fibroids or who are really struggling with the flooding associated with menopause, that it really decreases that uterine bleeding. We know if patients are iron deficient, that if we give them an IUD and even if we don't supplement them with iron, their iron levels recover because of how great of a job it does at decreasing that bleeding. And then what people often don't know is that the IUD can offer enough uterine protection that you can actually use estrogen therapy alone to support perimenopause. So as we start to bridge and talk about the hormone replacement therapy, you're often getting 2 prescriptions. Unless you've had a hysterectomy, you're getting a prescription for both estrogen and progesterone. Estrogen is a major heavy hitter as far as like improving your symptom experience of hot flashes, etc. And part of the role of progesterone, although it does lots of things, is to protect your uterus. You don't have to do that if you have an IUD. For women who struggle with their mood from progesterone, the IUD plus estrogen treatment option is a great way to support women who've had PMDD or who struggle with their mood and are afraid of taking systemic progesterone. We can actually still give them HRT if they have an IUD, which is sometimes a overlooked option.
Yeah, we're seeing quite a bit of that, and you're great at that with the, because you're always up to date, Jordan. So we're always seeing, the patients are like, I have an IUD, is this okay? Absolutely, absolutely. We're treating it, you guys are really great to, with being up to date and knowing how to personalize that treatment. You're not afraid to add on that estrogen, understanding exactly what the IUD does. So yeah, we're seeing quite a bit of that, and they're doing, the ones who are on the IUD are usually, again, because they're super compliant, it's easy. They don't have to worry about it. They're very happy with that treatment. But then what happens when they start getting cramping and it moves or so on? Then we have to consider something else, right?
And that, I think, the question about like, when does it come out and whatnot, that's one that I often get asked, if that 5 years sort of bridges the
Yes.
menopause transition
Yes.
for people. And I don't know if there's really a right answer about that. My typical suggestion for people is that we don't, if as long as everything's working, like different, like with the pill, even if everything's working, we might want to change our mind about it as you get into your later 40s.
Yeah.
Whereas with the IUD, if you're 50 and you still have an IUD and you're using estrogen, I'm like, I don't know if we want to change it, right? Like if you're feeling fine and you're doing well,
Absolutely.
women can still have pretty significant bleeding episodes, past age 50. So there isn't this like, cutoff point that I'm saying, take your IUD out no matter how old you are.
Right.
Usually I'm suggesting that people fulfill that prescription
The
to the
five
end of the 5
years. Yeah.
years. Yeah. But what do you see, Miranda? And like, what do you think about that?
I agree. I mean, if they're comfortable, if there's no rush to take it out, if everything's working properly, and as long as, the estrogen is being balanced and the other, whatever symptoms may appear later on during that 5 year span is being addressed, right? Properly. So it's win-win for the patient.
Yeah, 100%. And then I think the last piece, like as we move into talking about HRT, like no matter how many times I talk about it, women are still sometimes surprised that they can start hormone replacement therapy before they hit menopause, right? Like while they're still having menstrual cycles, they're surprised that that's an option for them. I do think that the conversation is changing, but I still will meet those people that are worried about it. But can we talk through sort of like what those indications are for adding HRT for people, and when can they start?
When can they start? As soon as, well, as soon as they hit perimenopause, which was, they'll be able to. It's so funny because there are some women in their 30s who hit, right, perimenopause. You see it. So hot flashes, mood disturbances, issues with sleep. I think, so many things. I mean, taking the regular life stressors away, you have to determine if their bodies are either have too much estrogen and not enough progesterone, or as we know, progesterone starts declining in their 20s. So it's not unusual to start a little bit earlier and restoring them in small amounts.
Yeah, I think, if we follow some of the guidelines there, like HRT is the I'm going to say gold standard for treating hot flashes, and your hot flashes don't totally discriminate based on how old you are. And there are definitely people that can have night sweats and hot flashes in their early 40s, definitely have some people in their late 30s. And we're learning more and more about what maybe increases our risk of early ovarian decline or premature ovarian insufficiency. But things that are getting added to the list that maybe people would have been surprised about would be things like Hashimoto's thyroiditis or other autoimmune disease, which does seem to cause ovarian decline. Patients who've had infertility care, and it's not because the treatments you used caused ovarian decline, it's the fact that you needed fertility care is an indicator that you may have early ovarian decline.
Right.
Even endometriosis, right? Severe endometriosis is going to cause some ovarian damage and may give women those symptoms of menopause earlier than we expect. But it doesn't, like I'm saying, hot flashes don't know how old you are.
No, there's no discrimination. I know.
No discrimination.
Absolutely.
And so, starting that hormone therapy piece, like when women are symptomatic, I think that's the important piece here, is that's the shift in practice, is that we're not waiting for a particular date. We are treating as it's indicated, right?
Absolutely. So when a woman comes to you, you're not looking necessarily at the age, right? You're
Right.
looking these are the symptoms, and then looking at perhaps lifestyle initially, right? And then certain triggers. And are you still doing blood work for these women, or
It's a good question.
clinically? Yeah.
Yeah, it's a good question. Like in theory, we should be making the decision more clinically around perimenopause with the symptoms and the cycle length changes, et cetera. However, there's moments that, or there's other causes of their symptoms that we may want to try and rule in or rule out perimenopause above and beyond what we can assess clinically. So, I could come up with that example of like the person has an IUD and they have a history of depression and now their mood is low and sometimes they have night sweats and they're dieting, right? And I'm like, okay, like between that whole situation, are they like, is this old depression back? Is this under eating causing night sweats? Is this perimenopause? And sometimes blood work might give us, I always call it whispers of perimenopause, where we might find elevated FSH. We might find like an anovulatory cycle, which if people have had very regular cycles their whole life and we happen to catch them in a cycle they didn't ovulate, we can see that maybe we're starting to encroach on perimenopause, but it's more often definitely done clinically. It's just when it's getting confusing, or I'm not certain if the symptoms they're experiencing are hormonal or maybe from another cause.
Right. Well, that's interesting, because sometimes I wish I would be a fly on the wall with your, diagnosis, just so I can see both sides of both sides of the care. But from my end, what we usually do is that, when a woman does approach us, and it's great to be a woman because they'll most likely come approach a female and talk about their, let's say, symptoms, we would immediately just, kind of go through it quickly and then understand who to refer to, right? We want to send them to a hormone expert, but we don't know what's happening, because everybody does treat very differently, right? So in terms of, we used to see a lot of saliva tests, which, I don't know how you feel about that. But I do believe in the clinical symptoms, because women are very good at understanding that they're not just nervous and sweating, that they're being woken up in the middle of the night, and this is affecting, their quality of life. It's really interesting to see, though, what I love about, and I do love bioidentical hormones. I love, and I'm not just talking about just the compounded version. I think it's so important because the effect they get is so usually pretty quick compared to so many other things. So immediately they can feel like they can sleep at night, they can feel like the hot flashes are gone. Their moods are a little bit better. It's probably one of the most rewarding things I've ever, worked on.
I know. I love working with women. I see a lot of professional women. Like I see a lot of psychologists and lawyers and people that they rely on themselves, right, to show up in their work. And it's just not tolerable for it not to be that.
I really like how you said
right
that.
there.
Show up. Exactly. Show up in their true self, right?
Yeah.
And so
it is so rewarding when they come back and they're like, yeah, I feel great. Like I feel like myself, right? I can tackle all the things in my day, or all the things that I, had dreamed of achieving at this age. I'm able to do them, versus feeling like they've come over this hump and now are on some kind of steep decline, whether it's in their career, in their physical performance, or what have you. So, yeah, to me, I think, just trying to keep in the theme of pros, cons of HRT. I will say one of the challenges of treating with HRT and perimenopause is that one of our number one side effects is irregular bleeding with HRT. And you are already having irregular bleeding in perimenopause. And sometimes that can be a difficult, thing to navigate with patients, where, even if we put them on quote unquote the right plan, they may have bleeds in between cycles. They may end up with spotting as a consequence of their HRT, but then it's hard to tell if it's from their HRT or just from their perimenopause.
right.
I would say that's one of the most significant challenges. So for some women, if their bleeding is a real standout challenge for them, the IUD might in that time be that better choice, right? Because giving people HRT doesn't magically fix their bleeding. If anything, it just makes the whole thing like really cloudy.
Yeah, absolutely. And that's something that they have access to, right? You would offer that suggestion just to carry on if that's a significant concern. And again, it's all about managing expectations, because I noticed that some patients think that as soon as they're on the HRT and then they're in the perimenopause phase, that all of a sudden their cycles are going to go back to normal. And that's not usually the case. And so, yeah, it's really important to manage those expectations. And if it's a deal breaker, then you have an IUD to fall back on.
Yeah, I agree. That's such a great way to put it, because we do know that if we put people on HRT and they are in perimenopause, that their cycles do lessen, they get lighter, they come less often.
Yeah.
But that's over 18 months, right? Which is like, it also may have gone away on its own in 18 months, to be honest. But your hot flashes and things get better. It's just that the bleeding irregularity is this lagging improvement. And for some women, especially if that was their primary issue with their cycle, that we're not really solving it with the HRT. Absolutely. If anything, you might be a bit disappointed in that. And I will say that I definitely have some patients that because their ovulation is really haphazard, that when they happen to ovulate on their own, they may feel more breast tenderness or more hormonal symptoms during their cycle because, yes, when we give you HRT, we're giving you these like sort of micro amounts. If you ovulate on top of that and throw a ton of hormone into the ring, you're probably going to feel a bit PMSy. And
absolutely.
Yeah, but it's interesting because they may have felt PMSy either way, right?
Absolutely.
It's just that,
well, there you go. that's also very personal, right? That could have been the case since they were, since they got their, in puberty. So you don't know what that situation. I think it's so important to understand what the patient is expecting and managing those expectations in a very, that's what I find the hardest thing that we do, because when you communicate clearly, like everything's not going to be resolved, like, you could be bleeding, etc. And they're aware of that. They don't come back, frustrated, thinking that the treatment's not working. So that's why I really, sorry?
In 3 days.
Well, everything should work in 3 days now.
You wait 5 days. But you're bang on. And I think, if it's all laid out for people to understand what those pros and cons are, and that was kind of my goal of this episode, was that there's no right answer, there's no wrong answer. And your prescription in perimenopause will probably change 3 times, whether
Absolutely.
it's what you're doing, the combination, the dose.
It's so funny because that's the first thing that I tell people when they initiate, I just say, this is a great start, but you just please communicate with myself or the practitioner what's happening, just so that, because we will likely have to tweak. And it's not just tweaking the doses, it could be tweaking the form, right?
Yeah, I love having this open conversation with you, Miranda, because it brings just this nice, like, kind of like all players are like relatively equal, or maybe there's some standout, bonuses of using one form of hormone therapy over another in your 40s. But my goal with this conversation was to help people feel like, one, they had choice. And I think like engaging with a pharmacist and engaging with a pharmacist on your health team can be such a valuable resource that so many people don't even realize how much of a role you can play in helping them understand their options and communicating with their physician. But also to know that there's like kind of 3 different options and none of them are right and none of them are wrong. And so, but you should have like talked about all 3, right? I think every woman in their 40s deserves a conversation about all 3 options if she's struggling with hormonal symptoms.
I agree. And what's funny is that a lot of women who do come to discuss this with me, they don't know that they have all these options. Interestingly enough, they're not presented because it's usually, oh, okay, I want, X, Y, and Z done. And so maybe, a prescriber will just initiate what they know or what they think that, not necessarily what's in the best interest of the patient or addressing their specific concerns, and even thinking, being flexible and, a care plan. I think it's really important to start off with saying, this might work right now. Let's see how it goes. And then let's reassess in a year, instead of just continue the treatment that they're on and going on it forever and ever,
Yeah.
when I think that's the most important thing, knowing that there's options, that there's no right or wrong answer. It depends on where you are at a certain phase in your life, what concerns you need addressed. And I think it's important for people to communicate that, really effectively. And let's say you can't communicate that effectively, it's our job to kind of pull that out, right? With providing all those options, because then solutions are available.
Yeah, I love that. And it's a great note to kind of end on, that, your prescriber should have, and hopefully doesn't have, any ego in what gets chosen, right? That there's just options, and they all have benefits and risks and costs and compliance and side effects and pros, and really the decision that you make is yours. You should just feel good about being able to have that open dialogue about what it is you need right now, and then what you may need in the future. And I think that was kind of my goal for us. So I'm so grateful that you agreed to come on the podcast for us to talk this through.
You're great, Jordan. I thank you so much. And I love what you're doing I told you this before, what you're doing for women and your education podcasts. And I'm just inspired by you every single day. So thank you for having me.
Thank you for coming on. And we're going to put the website for Origins Pharmacy in the show notes. If you're in Ontario, when you're looking for that sort of like pharmacist to be part of your care, a huge percentage of our patient population, partly like we do live right next door to each other, which I'm so lucky that we have that experience. But looking for that like good pharmacy team to be as part of the decision making. We'll put that in the show notes. Thank you so much, Miranda.
Thank you, Jordan.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team. I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.